This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurosurgery titled Maximizing Tumor Resection and Managing Cognitive Attentional Outcomes, Measures of Impact of Awake Surgery in Glioma Treatment. This work comes out of the Sciarra University Hospital in Trento, Italy, led by Luca Zighiotto and colleagues.
This is a timely paper, Alara. We've known for a while that the prognosis for brain tumors, especially grade 4 gliomas, remains poor, with median survival often hovering between 10 to 15 months. We also know that patients frequently exhibit impaired neuropsychological profiles due to the tumor itself or our treatments. Awake surgery, or AWS, has become the gold standard to maximize the extent of resection, or EOR, while minimizing permanent deficits. But this study looks at a specific blind spot in our intraoperative monitoring: attention.
Exactly. While we map motor and language functions routinely, we don't always monitor attention intraoperatively. The authors define attention as the cognitive processes that enable the selection of, focus on, and sustained processing of information. It's the scaffold for almost all other cognitive functions, particularly the executive system.
Right. If the attentional scaffold crumbles, the patient's quality of life and professional activities suffer, even if their primary motor cortex is intact. So walk us through the study design. How did they quantify this?
It was a retrospective analysis of 64 glioma patients, covering both low-grade and high-grade gliomas. They compared two groups, those who underwent awake surgery and those who had a sleep surgery, or ASS. They looked at attentional performance at 3 specific time points: preoperative, 1 week after surgery, and 1 month after surgery.
And what tools were they using to measure attention? These need to be sensitive enough to pick up subtle shifts in the acute postoperative phase.
They used visual search tasks and the Trail Making Test Part A, or TMTA. For the imaging side, they used volumetric T1-weighted contrast-enhanced and T2/flare sequences to delineate the lesion and the surgical cavity. What's really interesting here is how they calculated the EOR. They specifically looked at supramaximal resection for both contrast-enhanced and non-contrast-enhanced tumor regions.
Supramaximal resection. That's a term gaining a lot of traction. We're not just taking the ball of the tumor. We're following the flare signal and pushing the boundaries. What did the results show regarding the attentional scores?
There was a very clear pattern. Across the board, there was a significant decrease in attentional scores 1 week after surgery. However, by the 1-month follow-up, there was a complete recovery to baseline levels. But here's the kicker. Awake surgery was identified as the only significant predictor of that immediate postoperative attentional deterioration.
That's a provocative finding. If we are doing awake surgery to protect the brain, why is it predicting worse early outcomes?
The study suggests it's linked to the EOR. AWS patients exhibited significantly more extensive supramaximal resections, particularly in those non-contrast enhanced areas. The data showed that these more aggressive resections correlated directly with the immediate postoperative attentional decline. Essentially, because the patients were awake, the surgeons felt empowered to push further into the quote-unquote functional brain, which led to a transient stunning of the attentional networks.
That leads us to the neuroanatomy. Did the authors find a specific danger zone for these attentional deficits?
They did. They used univariate lesion analysis and a multivariate network approach. They found a negative association between lesion in the default mode network, the DMN, and postoperative attentional scores. Specifically, lesions involving the anterior anatomical regions of the left default mode network were high risk.
That makes sense. The DMN is a large-scale functional system. It's not just one spot in the brain, it's a network. If we're doing a supramaximal resection in the non-contrast enhanced areas that overlap with the DMN, we're going to see a hit in performance. But we have to balance that against the oncological benefit. Did the study look at overall survival?
They did, and the results for the oncological side were quite compelling. They performed a Kaplan-Meier analysis focusing on isocitrate dehydrogenase wild-type glioblastomas, the IDH wild-type GBMs, which are traditionally the most aggressive. The awake surgery patients had a significantly longer overall survival. We're talking about a mean of 887.73 days for the AWS group versus only 553.71 days for the asleep surgery group.
That is a massive difference. Over 300 days of additional life for those glioblastoma patients.
For a resident or a fellow listening, that really highlights the surgeon's dilemma. On one hand, you have a higher risk of a transient attentional decline at 1 week, but on the other, you're potentially giving the patient an extra year of life.
Exactly. And since the study showed that the attentional deficit was transient, with a complete recovery at 1 month, the trade-off seems heavily weighted in favor of the more aggressive awake approach. The authors argue that the higher transient postoperative decline is essentially the price paid for an improved oncological outcome.
Let's dive deeper into the imaging analysis they used. You mentioned region of interest-based lesion symptom mapping and lesion network mapping. How does that help us in the OR?
It shifts our focus from just looking at the tumor to looking at the brain at risk. By using these mapping techniques, the study highlighted that several large-scale functional systems are involved in sustaining attentional processes. It's not just the site of the cut, it's the network that the cut interrupts. The takeaway for a surgeon is to be especially careful when the lesion, or the intended supramaximal margin, involves those DMN hubs.
This brings up a critical point about our current awake protocols. If we know awake surgery is the predictor for this decline, and we know we're hitting these networks, why aren't we monitoring attention while the patient is on the table?
That's exactly the conclusion the authors reach. They emphasize the need for standardized, reliable, and quantitative intraoperative monitoring of attention. Currently, we might do a simple squeeze my hand or basic speech repetition, but that doesn't capture the complexity of the DMN or the attentional scaffold. If we had a real-time attentional task, we might be able to achieve that same supramaximal resection without the transient drop in performance, or at least better counsel the patient.
It's about patient selection and tailored surgery. If I have a left-sided frontal glioma near the anterior DMN, I should probably be telling them, we're going to do this awake to get the best resection possible, which might improve your survival significantly, but you should expect to feel a bit foggy or have trouble focusing for the first few weeks after surgery.
Precisely. The study uses the phrase maximizing tumor resection and managing cognitive attentional outcomes. It's not one or the other, it's a management strategy. The use of RANO-resect group criteria and volumetric MRI allowed them to be very precise about what was actually removed. The correlation between the removal of non-contrast enhanced areas and the 1-week attentional drop is the most statistically significant link in the paper.
It's a great reminder for the residents that the flare abnormality in a high-grade glioma isn't just edema, it often contains infiltrative tumor cells. Taking it out helps survival, as shown by the 887-day mean OS, but that tissue is also functional.
And we shouldn't forget that even the asleep patients didn't necessarily do better long-term. They had less of a drop at 1 week, but they also had less resection and shorter lives.
So, to summarize the key takeaways for our listeners, 1. Awake surgery allows for more extensive supramaximal resection of non-contrast enhanced tumor regions. 2. This aggressiveness leads to a transient decrease in attention at 1 week, which recovers by 1 month. 3. Lesions in the left default mode network are particularly vulnerable. And 4. The survival benefit of this approach in IDH wild-type GBM is substantial.
And finally, we need to develop better intraoperative tools to monitor these networks in real time. The study is a call to action for neuropsychologists and surgeons to collaborate on more sophisticated intraoperative tasks.
Excellent summary, Alara. This paper by Zighiotto and the Trento team is a significant contribution to the function-controlled oncological surgery discussion. It moves us beyond just, can the patient speak, to how is the patient thinking?
It's a fascinating look at the future of glioma surgery.
That's all the time we have for today's deep dive. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.